there is no such thing as lung cancer. You know, there is lung cancer in individual patients. So last time when I did this, I asked a group much like you, I said, how many kinds of lung cancer are there? And so if I asked you that question, what would you say? 5? A lot of people say 5. Did I hear 30? So here's the answer, and it's a trick question. So how many of you in the room have lung cancer? Out of the ones, if you have lung cancer, raise your hand. Okay, however many that is, that's how many kinds of lung cancer we have in the audience tonight. Because every patient with lung cancer is different, and it really is more different than breast cancer or colon cancer or some of these other sorts of cancers. There's a term we use for this called heterogeneity, which means different. And the more we learn, the more we realize that every patient with lung cancer has a different biology to their disease. Now that's good and that's bad. That sometimes means no matter what your oncologist tells you about statistics, that you're going to beat the odds. On the downside, it means if we have a very effective treatment, it's not going to work in everyone. And that's why you'll hear a term called personalized medicine used more and more. Bonnie's association and its research arm, Alchemy, are dedicated toward that goal of taking cancer treatment and making it individualized for you. In other words, so that your treatment is different, the approach to your cancer is different from every other patient sitting out there in that waiting room. Everybody knows that a person's fingerprints are very individualized to them. They say no two people have the same fingerprint. That's true for your cancer, and what I call it is I call it a molecular fingerprint. In other words, the genetics of your cancer are very distinct. We can literally measure now with some tests called whole genome sequencing every single gene in your body, every single gene in your cancer, thousands of genes. Not all of those genes determine how your cancer is going to behave. Maybe there's only 10 or 20. Nevertheless, your cancer has a different fingerprint than everybody else's. What we want to do in the future, and what we're actually doing right now in clinical trials and research studies and as part of Alchemy, is we're trying to look at that fingerprint and then go back to the patient and say, we shouldn't treat you with this standard chemotherapy or even Tarceva that we would give the other patients sitting here because we need to do something different in your case. That's the personalized effect. So even though it may have worked in your case, there are a lot of patients who would have gotten that same chemotherapy and it wouldn't work. We want to increase the odds. In other words, we want to make your chances, like you're in Las Vegas, you know, we want to stack the deck so that your chances are better. Most patients with lung cancer compared to breast cancer, most patients are stage 1 or at most stage 2. Most patients with lung cancer are stage 4 or 3B maybe. And the reason is because there are no early signs of lung cancer compared to breast cancer. You know, breast cancer, a woman might feel a lump, or she might be doing self-exam. In other words, there's something outside of going to a physician that might pick up that cancer early. And so for lung cancer, if you develop a pain or a cough, it often means because the cancer is very advanced and it finally caused those symptoms. So the one good piece of news that I wanted to talk about tonight is cancer screening, lung cancer screening. So this the LCAT that Sally was in was kind of like a pilot study that suggested that using CT scans could pick up lung cancer much earlier in patients who were at risk, usually because they had smoked in the past. So this national lung screening trial that was just reported took that one step further, and it compared chest X-ray to CT scan. And there was a 20% reduction in the death rate from all the patients who got screened by having a CT scan. So I think that's also going to be important because it's going to change the dynamics of lung cancer. We're going to have more patients who are stage 1 and fewer patients who are stage 4. It is only for smokers right now, because they are a high-risk group. But Bonnie and many of you know that there's an epidemic now of an increasing rise of lung cancer in people who've never smoked, and it's not due to secondhand smoke. So let me ask this question. How do we know it's not due to secondhand smoke? I already told you the answer in a roundabout way earlier. This is like a quiz. It's the fingerprint. So that fingerprint, that molecular fingerprint that I told you about, there are certain genetic changes in that fingerprint that go along with prior smoking, and it also is there if you got your lung cancer from secondhand smoke, because it's the same carcinogens. So if you are a never smoker, you have a different genetic makeup. You have a different kind of fingerprint. And one of those genes you know about is EGFR. We now know about a brand new one just from 2 years ago, ALK, ALK. And there are a variety of others which are just being discovered. So back to Emily's question then. For patients who have never smoked, what are we going to do? We're not going to put the whole world through a CT scanner. So the answer is we have a grant at UC Davis, along with several other centers in the United States and Canada, to discover a blood test for lung cancer. Well, a blood test is cheap, it's simple, don't get any radiation, and we want to develop, it's probably not going to be one blood test, it's probably going to be a series of blood tests, but one tube of blood, so that we could actually do this on a routine basis. And this past Friday, we had a call with the investigators for this grant to link them to Alchemy, to link them to the Bonnie J. Adario Lung Cancer Foundation, so that we could all work together. But I'm hoping in the future that we will have a blood test, and that way we don't have to say, oh, there's no way to screen you because you were a never smoker. The media, patients, all think we're going to come up with a cure for cancer. So when people ask me this, I say, there's no such thing as cancer. There are these thousands and thousands of diseases. So even when we make a breakthrough, a lot of time it's for a very small segment of patients with one subset of one cancer. For them, it's a home run. That's another one of my analogies. People will say, well, what does this mean on my CT scan? I'm not sure what this means. And so I'll say, this is a home run. So again, I try to put it in ways that the patient will understand. Most of you actually didn't say I have non-small cell lung cancer. You said I have adenocarcinoma or whatever, or BAC. So that's a subtype. That's what makes lung cancer difficult, is there are many different subtypes. And up until recently, pathologists a lot of time didn't pay much attention, because they said, well, there are only two kinds of lung cancer, they said. There's the one with the small cells, and there's everything else. And the everything else is what we call non-small cell. Well, that's not very helpful. Non-small cell can mean squamous or adenocarcinoma or BAC or large cell or neuroendocrine. There's going to be a lot of different things. Now, to me, though, and here's the point I try to make to physicians all the time, is I'm not satisfied with that, because the adenocarcinoma or the squamous cell carcinoma, even though you may hear ads about histology, that's ancient history. The microscope by which we make histology was invented 175 years ago by Robert Hooke. We have molecular biology now. I don't care, to tell you the truth, if it's an adenocarcinoma or not. I want to know that molecular fingerprint. So for your question, I guess what I'm saying is that if we dig deep enough, drill down, we'll know much more than just the basic diagnosis. We'll know about the whole biology of your cancer. And right now, there are a few aspects of that we can take advantage of for treatment. In the future, there will be a lot more. And that's why I mentioned earlier, one of my patients recently said, well, why should I get this molecular test through you? It's only going to be 7 genes, and I can go to Dana-Farber and they'll give me 1,000 genes. And I said, well, what are you going to do with the information? He said, well, what do you mean? And I said, there are only drugs for 7 of those genes. So what are you going to do with the other genes? And he said, well, I don't know. I thought it would be interesting. And I said, it may be really interesting, but it's not going to help you right now. So, oh, and that's the other thing I try to do is I try not to use up my patient's biopsy by doing needless tests. Because maybe next year there'll be drug number 8. And if I've used it up looking at 1,000 worthless genes, then no disparaging effects to Dana-Farber. But, you know, then I won't have that biopsy around and I'll have to try to get a new biopsy. Back here, this sign, this alchemy sign, or here, that's what's good. Because we're initiating this clinical trial I mentioned, CASTLE, where we're going to get the molecular fingerprints of all these patients and help oncologists figure out how to personalize their therapy. So that's very powerful. And it's that sort of effort, and it's being sponsored through the Bonnie J. Adario Lung Cancer Foundation and Alchemy, which I think is going to really change how everyone looks at lung cancer patients. You know, we didn't talk about the lung cancer stigma tonight, but we did talk about the fact that a lot of patients, even if they smoked in the past, their lung cancer is not from smoking. So we need to change everybody's perception, and we need to tell people that there are better things coming, and they are. And, you know, you can say, well, you know, things are pretty limited right now, what's available for me. Well, 2 years ago, we didn't know about ALK, and that is a blockbuster. It's pretty uncommon, but if your cancer has the ALK fusion, there is a drug which has a 70% response rate. There are going to be more ALKs. In other words, we're going to find out some of these questions, the answer to some of these questions that you've asked tonight. And so I think there are better days coming, and luckily, you know, Bonnie and Tony and the whole group here are part of it, and I am as well, because I would not, you know, miss being part of this, and that's the reason I came down tonight. So thank you very much.